My screen is visible, no?
Yeah. I think we can ask Sir to share his video till then, right? Starting.
Which
When
video?
you're like his.
Good evening, everyone. We welcome you to the online teaching program for postgraduates in pathology. And today's topic is minimal or measurable residual disease in acute leukemias by Dr. Prashant Tembare, Professor, Department of Hematopathology, ACTRAC, TMC, Mumbai. And the chairperson for today's talk is Dr. Gaurav Narula, Professor, Pediatric Oncology and Health Sciences, TMC, HBNI, Mumbai. We welcome you, sir. And the webinar host are Dr. Sumit Gujral, Professor, Department of Pathology, TMH, Mumbai, and Dr. Anita Bogus, ma'am, Lab Director, Consultant Pathologist, Center for Oncopathology, supported by Tata Trust, Mumbai. And myself, Dr. Priyavatna, I'll be moderating today's talk, along with Dr. Pratyusha, attending Consultant Department of Pathology, Rajiv Gandhi Cancer Institute, New Delhi. And these are some of the reminders. If there is any connection interruption or the WebEx section is slowing down, please log off and log in back again. And if you have any queries, please type in the chat box. Questions will be taken at the end of the talk. And these are some of the disclaimers. So now I invite Dr. Prashant sir to start the talk.
Thank you. Let me share my, okay. Okay, is my screen visible and is it full screen?
Yes, sir.
Okay, hi. So hello everyone. I can see there are probably 65, 70 people attended and probably a few more people. And when I'm looking at the names, most of is actually looks like a new pathologist, budding pathologist or resident of pathology. So what I'm going to do is keep it as simple as possible. And as our moderator has already said that we will have questions in the end. So let me start. So today what we are going to discuss is minimal or measurable. So minimal was old terminology. Measurable because we have now advanced technology where you can measure as much as possible, and with advancement in the technology, the level of measurement, the sensitivity of measurement is going deeper and deeper. So that's why instead of minimal, nowadays we call it measurable residual disease with given technology. Okay, so these are the points which I'm going to discuss with you all today. That what is MRD, briefly why it is needed, and very in short what are the different methods, and if we compare them, what are their advantage and disadvantage. Today's talk I will be focusing on mostly on flow cytometry based MRD, because it's not possible to cover all, and I know more of flow cytometry, so I'll restrict myself to flow cytometry based MRD. And what we will also in that we will discuss how do we approach BLL MRD, TLL MRD, and AML MRD with an example. And then we will have Dr. Gaurav, who is a clinician, oncologist, who will also give some comments and his inputs on the clinical aspect, and then we'll have some questions. So if you look at this is a slide, you can see there is these are the data from two different institutes from United States. Okay, one is from St. Jude, which is on the pediatric ALL data, and if you look at one is from MD Anderson AML data. Now these are the Kaplan-Meier curve basically, where it shows that probability of event-free survival, and this is both basically survival probability. Now, why I started with this figure is because you can see earlier when in 1960s, then 70s, 80s, and now to look at in ALL, the earlier, if you look at the survival probability after around 5 years was very only 10% of the cases. Then with improvement of the therapy and risk factor, it has become 36%. As we are improving on predicting the risk of relapse, as well as different prognostic factor, as well as the improvement of the therapy, general conditions, the probability of relapse or event-free survival is becoming better and better. Now, but if you look at the question is why there are in spite of the given treatment at given time point, there were the cases which were relapsing. And because of that, the relapse-free survival. Relapse means the recurrence of the disease. The disease is recurring. Now, major cause of treatment failure is the relapse of the disease. Means the disease coming back after given therapy. Now, because the disease is coming back, the treatment options after relapsing are very few, and they are not that successful, leading to the ultimately, death of patients. Okay, so mortality. So that is this, and there is the, and that's why when we are giving treatment, we are looking for the different biomarkers, different laboratory clinical methods where we can predict which patient is going to relapse, meaning the after given therapy, and which patient will respond very well. Okay. Now, as I mentioned, one is when you look at the relapses, one is the inadequate therapy for the given disease. There may be, sometimes let me start. Okay. So sometimes because at that time the treatment is not adequate, which is not able to clear the disease. That is one thing. The second is refractory, means sometimes the biology of the disease in such a way that even with the best treatment, the disease is so refractory at that time point, it's not getting clear. Or one of the commonest cause is the leftover disease, means the part of the disease after given treatment is still there. Okay, and because the disease is still there, the small part of minute part of the disease is there. That disease, that leftover disease is basically represent the refractory part of the disease, which is not killed by the given treatment. And it eventually, after a period of time, it grows back, causing the recurrence or relapse of the leukemia. So ultimately, this is the ultimately whatever biology is there, whatever the treatment is given, whatever the host conditions are there, it leads to the leads to or results in a proportion of refractory disease or a small part of disease which is there, which ultimately after some time, relapse or grow back. Okay, so that residual disease. So we have to find out after given treatment, after the initial treatment, whether any leftover disease is there. If there is a leftover disease, that means we know that this patient is going to relapse. If there is no leftover disease or residual disease there, that means the initial treatment is successful and we can continue with the protocol. Okay, now based on the whatever biomarkers, we can decide if the disease is bad. We can always, we have two options. We can give a high intensive therapy, or we can give, less intensive therapy. Less intensive. If you give the less intensive therapy, then because this less intensive therapy will not clear all the disease, there is chances of relapse is high. Now, if you give intensive therapy, then it increases the cost. It causes the toxicity to the patient, which itself can cause morbidity and mortality, which is therapy-related death, or it can also cause eventually lead to the secondary malignancy, like secondary ML, therapy-related ML or therapy-related malignancy. So you need to balance the treatment, right? So that means what you have to adopt a risk adapted therapy. Means that you can we have to give the treatment intensive therapy to the high risk patient, and we have to give less intensive therapy with low risk patient, so that the low risk patient where patients do not have risk of much risk of relapse, you can manage those patients with less intensive therapy, and we can avoid the toxicity of the therapy as well as reduce the cost of the therapy and also avoid the probability of developing secondary cancer. And because we will be giving we can decide the patient which can be given intensive therapy based on the risk, risk based therapy. So in those cases where the patient is high risk, we can afford and we can give the intensive therapy and avoid the risk of relapse. So we have to balance. So for balancing, there are multiple parameters. Okay. Now, what are the major prognostic factors which eventually we are currently using in the clinical practice? The major risk factors are like age at diagnosis. It's common. That is a host-related, means patient-related risk factor. Initial WBC count, initial blast count, which is disease-related. Then subtype, what type of disease there, which is whether it is BLL, whether it is TLL, whether it's AML, in AML, whether it is monocytic leukemia, APML, so which type of leukemia it is there. Then disease genetics, which is a very important factor of number of chromosomes, hypodiploid, hyperdiploid, which translocations there, 821 translocation, fusions, which mutation, NPM mutated, FLT3 mutated. So disease basic, and then response to the initial treatment. So how the given disease is responding to the initial treatment, which is very important, because at the end of whatever age, host-related factor, whatever microenvironment of tumor, whatever disease immunophenotype, or whatever genetics of the disease, ultimately it will can be concise or it can be evaluated based on the response to the treatment. Okay. And the response to the treatment, initial treatment, is measured by the leftover or residual disease after a period of at the end of initial treatment, which is also called as the induction therapy. Okay, so how do we assess residual disease? In a layman term or in a broad term, if you have a tumor, palpable tumor on physical examination, if a 10 centimeter tumor become 2 centimeter tumor, then we know there is a reduction, but still tumor is there, right? So if there is a lymph node, large lymph node, 6, 7, 8 centimeter lymph node, which is or mediastinal mass, which is reduced to 2 centimeter, we know still there is 2 centimeter mass is there. That means physical examination. Then radiological examination of taking from plain X-ray to advanced MRI or FDG PET scan, where there is residual disease. In leukemia, we generally go for the bone marrow, look at the microscopic evaluation, whether there are the blasts are there or not. Traditionally, we are using 5% cutoff on the morphological microscopic blast percentage, where we call it as a complete remission. Complete remission if the blasts are less than 5%, and if blasts are more than 5%, that means bone marrow not in remission. That's what we used to use. Now, but that is still a tool to high level detection. High level means the disease level to detect on microscopic evaluation has to be 5%. Now, but still, you can have a disease below that, which is submicroscopic, which need sensitive or deep techniques or methods to detect that residual disease, which still can cause relapse or recurrence of leukemia. So what is MRD? MRD, if you look at MRD, is basically the level of residual disease which cannot be detected by using just plain morphology, and which need more sensitive technique like flow cytometry or polymerase chain reaction or the PCR molecular method. Okay, just in a plain word, if you look at here, if you take this is at a diagnostic bone marrow, for example, this cartoon, if you look at this cartoon, and the red dots or red circle represent disease or blast, okay, at the time of diagnosis, and blue circles or blue dots represent normal hematopoietic cells. Now, when the patient received chemotherapy, the majority of the disease disappeared, but still a small proportion of disease can still be there, which is called as minimal residual or measurable residual disease. Okay, and this disease basically ultimately eventually, depending the level of disease present in the bone marrow, patient's bone marrow, causes relapse. If you have higher level of disease, it causes early relapse. If there is very low level of disease, it can cause late relapse. Late relapse means after 3 years, 5 years, 7 years, something like that. But early relapse means within 1 year of the starting treatment or diagnosis. Okay. So why do we want to evaluate the disease? Once, of course, a need for identification of high risk patient, which I already mentioned, to decide whether whether to change, whether to identify high risk patient. And as I already mentioned, there are multiple factors based on the patients. The high risk can be defined based on the patient's age, WBC count, based on the tumor burden, that which is like a WBC count, then genetics, tumor microenvironment also play important and treatment response. Now, as I mentioned already, that all these factors can be evaluated at single time point using the MRD. Because all this now it has been proved, no matter what is the age, the MRD, that is minimal residual disease, is independent of whether it is MRD, whether what was the tumor burden, whether it is whatever is the genetics. If the MRD is there, the chances of recurrence or relapse of the disease is very high as compared to the patient where the minimal residual disease or measurable residual disease is absent. Okay. Now, as I mentioned, depth is also important. So if you have a detectable disease at very high level, then chances of relapse is early. As you go deeper and deeper, if you are given initial treatment can clear the disease, and the residual disease or the measurable residual disease is very low, the chances of relapse are still there, but usually late. But the target of current modern medicine is such a way that you reduce the level of disease in such a low level that it will not there is the chances of relapse will be almost none, and that phase is basically cure of the disease. Okay, and to get there, to achieve that target, we need a sensitive techniques to identify this residual disease, so that we know that what level we need to stop therapy, or what level, if the residual disease gone down, we know that the patient is cured. Okay. So there are multiple time points where you have to evaluate the disease. Generally, the general time points when the patient started therapy is post-induction. The second time point is post-consultation, that is at the end of consultation. And then if the disease is still positive, we can follow up regularly. And if the disease is negative, then whenever clinically indicated, you can evaluate, or at the end of maintenance therapy. Okay, sometimes if the patient is going for transplant, then pre-transplant and the post-transplant day 100, usually we go for the MRD assessment. Okay, so as I've already mentioned, these are the percentage, and our target is to go, that below 0.1 in 1 million cells, if quantifiable. That is the current target for the technological target to evaluate the level of disease, minimal residual disease. Now, there is another advantage or another importance of MRD is MRD guided therapy, because we know it has been proved beyond a doubt that no matter whether you are dealing with ALL or AML, if there is MRD, the patient is going to relapse based on the levels. Currently, we are using in ALL, we are using 0.01%. In AML, we are using 0.1%. But if disease is there, and we know the patient is going to relapse, then now there are many clinical trials going on which are based on MRD guided therapy. That means if MRD is positive, at that time point only you can modify the therapy and you can change the outcome of the disease. Okay, this is Indian. Currently we are doing, Dr. Gaurav will may probably give more idea, but currently we are part of a national, trial, which also decide based on the MRD whether the patient is standard risk or high risk. And if the MRD is positive, then it goes to the intermediate risk or high risk, and we can change from 3 drug to 4 drug regimen. So that means we are planning or we are changing our treatment based on the presence or absence of residual disease. In the same way, even AML, especially post-transplant, the people are already planning that if the post-transplant in MRD is positive, then the patient is receiving donor lymphocyte infusion, and the clinical trial or the strategies which has been adopted, or at least the clinical trials are designed or being conducted based on whether the patient's MRD is positive or negative. If MRD is positive, they're planning to change alternative therapy or intensification of the therapy or consolidation phase, something like that. So that means MRD being used, at least in clinical trial, as a guide to change or modify the therapy. Okay, now what are objectives of MRD analysis? When we have decided we want to evaluate the MRD, but there are objectives of any technique, whatever technique we are using. First is to detect residual disease among or in the other hematopoietic cells, because whether we have peripheral blood or bone marrow, at the time of induction you have very small tumor cells, and the majority of the cells are other hematopoietic cells. So one objective is to identify the disease or the tumor cell among other hematopoietic cells, which can be very similar looking to that of the residual tumor cells. Then quantify optimally. So that means you have to calculate is optimally, and then to assess. And the third objective is to assess representativeness of the sample. That means if the given sample is representative or hemodilute. If usually we use bone marrow for the MRD assessment in majority of acute leukemia, and bone marrow can because of the patient's bone marrow condition or because of the faulty technique, you can have hemodilution, means dilution of bone marrow with peripheral blood, which can also reduce your level, or in fact which can also cause false negative MRD results. So that's why you have to assess whether the bone marrow sample is representative or not. So those are the three objectives of MRD analysis. As I mentioned, assessment of MRD in acute leukemia principally can be divided, the techniques can be divided in two methods. One, based on the antigen or the proteins. Okay, because the tumor cells, they have typical pattern of antigen expression, protein expression. So we can identify the disease based on the presence of protein on the cell or inside the cell. And the second is based on the molecular techniques, like either you have used a particular mutation, fusion, or rearrangements like T cell receptor rearrangement or immunoglobulin